All right, good morning, everybody. For those of you who don't know me, I'm Bill Potterly. I'm Director of the Institute for Clinical and Translational Sciences, and I would like to welcome you all to our annual ICTS Symposium. Let us just start, as we have been doing more recently, recognizing the historical and cultural setting of where we are. As you all know, we're in St. Louis, but this is the ancestral unceded territory of the Illinois Confederacy, the Osage Nation, and the Missouri tribe. And recognizing and acknowledging the land and the ground beneath us as a way of honoring, expressing gratitude for the people who are on this land before us, and also will come after us and remind us of our responsibilities to the people who have gone in the past and the people who will be here in the future. So we have a change in the agenda, as I think some of you may realize, and I'll come back to the structure of the meeting a little later, but unfortunately our keynote speaker, Dr. Ruth O'Hara from Stanford University, was taken ill with COVID on Wednesday evening and feeling miserable, but obviously not appropriate for her to travel. And although she did offer to give her talk by Zoom, I really felt that with the fatigue and misery that acute COVID can bring, and it would be 7 a.m. in the Bay Area, that this was not an appropriate thing to do. So she has kindly agreed, and she is a world authority in mental health. So Dr. Lindsay and I will bring her here next academic year as a visiting professor, and she will talk to both the ICTS and the Department of Psychiatry at that time. So what we have done is, rather than have any keynote presentation, you're just going to have to listen to me a little bit longer. And then we'll bring up our two panel discussions a little earlier, so we'll actually hopefully be finished a little bit earlier. I don't think too many people will complain too much about that. So just to remind you, the ICTS, the Institute for Clinical and Translational Sciences, is designed to accelerate clinical and translational research and advance discovery, knowledge, and innovation to improve health outcomes and benefit healthcare. And fundamentally, this mission statement in any form or other is really what all academic medical centers aspire to be and do. Some do it better than others. Our ICTS really works around a number of pillars that bring people together, connecting them, focusing on education and particularly early career development for clinical investigators, but help also people disseminate their work and think about how to collaborate. We are a consortium, although it's predominantly located in and led by Washington University in St. Louis. It is a consortium of other education facilities, and we've been emphasizing in particular the collaboration with the University of Missouri and Columbia to enhance the availability of clinical research for a much wider population, including a rural population, as well as our hospital partners. And I just want to remind you that the NIH and others really look at translational research as a continuum. The discovery part, which is what much of happens in our labs and around this university and medical center, leading to early human trials, more advanced human trials, dissemination into populations. That's usually regarding the healthcare system, and then beyond that to the general community. And it's really important that we think about this, and I'll come back to it in a few minutes, to think about this in terms of the impact. And one of the things that we have really emphasized is to think about people's work, not just in what Doug Luke at the Brown School, who came up with this model of the translational science benefit model, that traditionally academics think about counting widgets, papers, grants, patents, H-index, etc. But really, is that what you really want your work to be remembered for? It's really about impact. And impact can be clinical impact, community impact, economic impact, and policy. And I would encourage all of you to take a look at this website. And one of the things that I think is really good is that impact is now recognized at this medical school as an important part of what we evaluate our faculty for. It is not the only criterion, obviously, but within the clinician track, as people may not know, we have added terms like a research clinician and an entrepreneurial clinician. In the research track, there's a recognition of team science and entrepreneurship. And in the investigator track, there's an increasing recognition called out now for both team science and entrepreneurship. And really, this is the first attempt to look at impact. So talking about that impact, I'm going to give you a few examples of some of the work that has been either published or publicized in the last year, to just show you the breadth of what this really means. And some of you will know that there has been a lot of work done, investigators in the departments of pathology and medicine on the whole issue of trying to better phenotype various forms of cancer, blood cancers, leukemias and others, using genomic testing that will then ultimately allow more precise therapy. And this led actually last year, this has been highlighted previously as a major part of work, and this work has been going on for over 10, 15 years. And received funding support at various stages from the ICTS, and has been recognized from a scientific perspective. But I think one of the real important things in terms of its impact was that last year Medicare approved this for reimbursement. Because if you are going to develop new technology, new tests, and make them widely available, somebody actually has to pay for them. And this is an important goal. You'll hear more from Fumi later as part of our panelists, but we really wanted also to highlight the work he has done for quite a number of years to progress our understanding and then ultimately treatment for Wolfram syndrome. And as I said, Fumi will be a panelist, and we'll talk a little later about how this was done. But again, as from the ICTS perspective, we really want to highlight his success because at various points along this journey, the ICTS made an investment in this that we think and we hope accelerated the process. Similarly, we also have funded and supported investigators from biomedical engineering and the engineering school, again working in collaboration with investigators here at the medical school to improve diagnostics and ultimately improve impact. And these are just a few more examples. I think one of the things that I think, and you'll hear a little bit about this in our second session, is a clinical trial that was published in the New England Journal of Medicine, which showed that something that was being done routinely in heart transplantation, in giving thyroid hormone, was actually found to be useless. And yet it had been done on the basis, it had been introduced as policy on the basis of clinical, observational clinical trials. And it had become policy, and no, there was never a randomized controlled clinical trial. And investigators here want you put together, in collaboration with blood banks across the country, or transplant centers across the country, I should say, a randomized controlled trial that showed that this was a complete waste of time. And we don't always highlight negative studies, but there is an important reason to do a study like this, because the resource implications were quite considerable. We have supported the development of a mobile health research core, and led by Ginger Nichols out of the Department of Psychiatry, and this, I think, as we move forward, will be a very important issue, and so on. The other aspect, however, when we think about this journey is partnering with the community. And we have invested significantly in our Center for Community Health Partnership and Research to offer service to engage with the community and to help investigators engage with the community. We have a community engagement studios, a community advisory board, and various other opportunities for both funding and education. This is increasingly important. I mean, one of the things that anybody who does any clinical research funded by the NIH will see an increasing emphasis by the NIH on the involvement of the community and on ensuring that there is diversity within enrollment of clinical trials and clinical research. And we have the tools to help investigators. And it's not just about getting grants. It's really about actually improving the quality of your research. Because if your research is not meaningful to the community that is affected by the disease that you're trying to treat, then ultimately its impact is going to be significantly less. And, but there are also important scientific reasons, and you'll hear some of this discussion as we move through it, and that it is very important to bring disadvantaged and previously underrepresented communities into the discussion and into the ultimate engagement in clinical trials and clinical research for a number of really important reasons. The first is that scientifically and biologically there may be differences, and that if you confine your study to a very narrow population, it's only relevant to that narrow population. And it may not have the same impact and the same relevance, and it may actually be misleading. The second thing is that we have seen so much mistrust and miscommunication over the last 4 or 5 years. Unfortunately, often politically exploited. But the fundamental mistrust needs to be addressed by us as the investigative community. And we have to continue to engage with people for them to understand the value of science, the importance of science. And it has to therefore be relevant not just in the abstract, but to them and to their families. And so engaging with previously excluded or underrepresented populations becomes critically important. And finally, and I will tell you this from the experience of young investigators who have gone through our programs, talking to affected communities, talking to patients with the disease raises new questions, questions that you ought to be answering. And again, I think you'll hear one example when Fumi talks about his engagement with patients who have the Wolfram syndrome and other rare genetic diseases, and how important their voice becomes, not only as a supporter for the research, but also helping the investigators formulate the right questions that will answer what the patients actually need. As part of our efforts also in terms of advancing equity, we've recognized that one of the things that is a problem when you try to engage underrepresented communities is that if the workforce that's engaging with them is predominantly from one sector of the community, and in other words, that they're constantly receiving information and requests to participate in research from people who don't look like them, who don't have their experiences, then it can be a problem. So we have addressed this by establishing a program for young faculty who are just starting at WashU called ProudMed, a program for underrepresented medicine for equity and diversity. Our first cohort started last year, and we're accepting applications for our next cohort. And it really has been an outstanding success. But parallel with this, we also have very important and significant efforts to increase the diversity of the workforce, the clinical research coordinator workforce, because that's also critically important. The first person or the most important contact a patient may have with a clinical research environment will be the coordinator. And if that person is, we can increase the